So questions. I'm going to field the questions, repeat them so they appear on the videotape. I'd ask that you introduce yourselves just so we're aware who we're talking to. And I hope we haven't put you all to sleep. I'll start with Lewis Kaplan.
When you introduced me, thank you. Two questions. Is the Ministry going to produce an integrated care strategy? I know you've got an investment strategy, but is there going to be a more detailed ministerial level integrated care strategy from which organisations can sort of fill the charter of their frameworks or whatever else they're going to do? That's the first question. Second question is, there's going to be a lot of people applying for this funding. There are going to be a lot of good ideas, and presumably you're only going to be able to fund a small proportion of them. Is it possible to have a tick box somewhere on the application that says, after the tenders have closed, people are happy to provide their application and their ideas into a public space where others can see and learn from, some sort of clearinghouse, so we don't lose all the intellectual endeavour of the process and only focus on the few that actually get the dollars?
Okay, thanks, Lewis. So 2 questions. Is the Ministry going to provide an integrated care strategy to provide some sort of guidance? And secondly, are we going to facilitate a clearinghouse approach to the proposals that come in so that information is exchanged? The answer to the first one is there is already an integrated care framework that was launched by the Minister at the date of that press release. There is not at this stage, and we don't actually have plans imminently to produce an integrated care strategy document for the reasons I alluded to earlier. There is no right model anywhere in the world of integrated care. There are objectives, there are initiatives that may be applicable in some areas more than others, but there isn't something that we can give you as a blueprint for how you land integration in your local setting. That's specifically what we're seeking to get from you. Now, it may well be that in the fullness of time, having invested in these innovative strategies, understood what works within our environment, we will produce a strategy document that will show the whole of the system, indeed the whole of the world, how integration can work within the many different contexts in which we operate. But at this stage, we don't have that. In terms of a clearinghouse, I think we'll have to take that on notice. I would imagine there would be support from some of the people bidding for this money to share that information. There may be less support from others. I'm very mindful that we have a number of people from the IT sector that will be looking to leverage some of their ideas in a way that may carry with it some commercial in confidence, and that clearinghouse may not be an appropriate mechanism for that. Yeah, and I guess what Nigel flagged is this revamping of the Archie website and the opportunities to feed information in through that. We are very interested in this process in spreading the best ideas around the system, so we'll look at ways of doing that, Lewis. Up the back.
Hi, I'm Julie Redfern from the George Institute, Global Health. I have a couple of very practical... Oh, thanks. I have a couple of very practical money-related questions. One is, what about the cost of software and sort of electronic development costs? Can that be included in the budget?
Yes is the answer to that.
Okay.
Sorry, the question was, can you include costs of software and electronic development in the budget? And the answer is yes.
Okay. And the other one is, with partner support, does that include in-kind and cash support, or only cash support?
Okay, so does partner support include in-kind and cash support? And the answer is yes.
Okay. Yep. My last question is, I'm gathering this process is for LHDs outside of the demonstrator LHDs. I just wanted to double confirm that.
Yes. Is this funding pool just for those non-demonstrator LHDs and their partners? Yes, is the answer to that. So yes is all around. Thanks very much. You can hear the questions? Fantastic. I'll stop repeating them. So we've got one in the middle and then one down the front.
Josephine from Southwestern Sydney Local Health District, Rohan. Just want to ask, I know the 3 demo sites, LHD doing the proposal and working hardly on that. Whatever we've been thinking may be closing to that. So is there any chance that we have high levels of some of their strategies so we don't repeat the same thing before the submission, I mean?
Yes, I'm just not sure when we will have... it's incumbent on our demonstrator sites to share their work with the rest of the system. So we will be looking for every opportunity to do that. Whether we will have finalised proposals available in a time that would allow you to feed any of that into the application, I'm just not sure. If we can make that information available, then we will, and we would do it through the website. And it's a good idea. In broad terms, the demonstrators are trying a number of different solutions: structural solutions, cross-agency cooperation solutions, targeted for different subgroups of their populations. Much of the stuff that we've been talking about today that's suitable for their local district. One down the front.
Chris Levi from Hunter, New England. That was essentially the question. Are you able to share any of the detail of the activities that are underway already to avoid duplication or excessive overlap of effort?
Yeah, so certainly in terms of our statewide enablers, then we have been and will be making information available to the system about the development of those initiatives, and those are largely IT-based initiatives. In terms of the specific work that the demonstrators have been doing in designing their proposals, there has been communication of some of that information through the Senior Executive Forum, so some of your Chief Execs will have some idea of the general directions that people are working on. But I don't think you should be afraid of duplication. If you've got good ideas that are just as good as what the demonstrators are working on, there's nothing that would preclude us considering those good ideas for funding through this process. There's one down the back.
Is there potential for support from
Stuart Riley from Far West.
from the ministry around changing some of the structural constraints, and I'm thinking industrial issues, some of the funding relationships with the Commonwealth? Is there potential for looking at this also as a process to play with those things that define the system?
Yeah, so if you can, Stuart, if you can show us what those are and the need for them in the context of your proposal, and ideally also show us the way to do that, that'd be much appreciated, particularly in the interactions with the Commonwealth. So, look, there are things that are fundamental challenges to us in providing integration across that primary care, acute care divide. We're well aware of those things. What I would hate you to do is to let those things be an absolute impediment to your work going forward. If your proposal is dependent on us being able to convince the Commonwealth to make a major change in, the Medicare agreement, I think it's going to be challenging for your proposal to be funded. Because just in terms of the timelines of what we're dealing with, that would be challenging. Nevertheless, if part of your proposal would be enhanced by that sort of change, and there's a good case for us to do that, the Ministry will be very open to exploring that. As you know, we've been exploring the issue of the Section 19.2 arrangements with the Commonwealth and are progressing that. Over here on this side.
Hi, Kathy Maloney, Murrumbidgee Local Health District. Ken mentioned that he would make a team available to provide assistance around looking at, I'm presuming, linkages and processes. Just wondering if you might expand on what that entails.
Over to Ken.
I guess what I meant by that was that in putting a proposal together, given what I talked about that's happening within the hospitals and the whole of hospital program, if there's anything you're doing that in the proposal that you think needs to be lined up with that, and I certainly think there needs to be some sort of line-up, my team could be available to actually talk through in more detail what we're doing, what our plans are, and the outcomes that we're after, which may then help you with your end of the proposal.
Solange. Oh, sorry. Greg first and then Solange.
Greg Stewart, South Eastern Sydney. There's nothing explicit in the criteria about evaluation, and when we're doing pilots like this, we clearly need to have that perhaps a bit more explicit than it is. I assume they had criterion 2, sorry, got to get the word right, sustainability, scalability and transferability will include some assessment of how these pilots would be evaluated. But I just want to make the point that that ought to be a pretty fundamental part of the bids.
Yep, as a former Chief Health Officer, where Greg's very focused on evaluation quite rightly, and there is an evaluation framework that's in development for the entire program, and we would expect that each of the proposals that we receive will be able to evaluate their work to demonstrate the success. Frankly, if I'm to go back to Treasury next year to ask for more funding for this sort of initiative, I need to have information that supports that this is a wise investment. So I'll be very interested in the evaluation frameworks that you put into your proposals to make sure that you're delivering success. So Solange, and then there's another one down the back.
From ENCOS. Rowan, congratulations to both you and Catherine for getting to this point. I think when Australian Healthcare and Hospital Reform Association had a seminar back when the National Health Reform Agreement first came out, the first one, and we were talking about actually whether it was going to be successful and what was going to be needed to make it work. It was these sort of things that were coming up from all the participants at that time about having flexible funding available and the leadership and the appropriate governance structures around it, so that's really great to see. Probably following on from what Greg was saying, I'm just in terms of some of the evaluation and outcomes measurements, is equity going to be one of the focuses of deliverables around these projects? And a second question about the innovation exchange, will that be accessible to non-government organisations, or is that just through the Ministry or Health intranet?
Yeah, so the innovation exchange is accessible generally. In terms of the equity question, where LHDs and their partners can identify a particular population that is in need of, you know, your innovative approaches to delivering better healthcare, more integrated healthcare, we would welcome those proposals. Now, I would expect, and we're already seeing with our demonstrators, that some of their proposals and some of the work that we're expecting out of this process is focused in addressing certain disadvantaged groups within our society and dealing with some of that equity issue. What we haven't done through this process is limit the funding proposals just to disadvantaged groups in our society, because fundamentally it isn't just, you know, any one group in society that suffers from the fragmentation of healthcare, but we would welcome proposals that deal with some of the equity issues. Down the back.
Hi, I'm Dave. I'm actually a clinician. I used to work at Liverpool and I work at Sydney Hospital, so I was very excited to see this concept come up. My question is basically, as a fairly green novice in terms of filling out these big applications with all sorts of detail required, what help can you provide us at the coalface if we come up with something that we think is innovative and truly could deliver better care to our patients? What resources can I have at my disposal to help come up with a good proposal?
So resources to come up with the proposal?
In terms of filling out budgets, and these are things that, you know, as a clinician we have no experience with, so who do I turn to?
So I'd encourage you to make contact with your local health district management who have resources within their teams that can assist with this. Clearly any proposals coming out of an LHD will need to be authorised by the local health district. So the chief executives will be expecting clinicians like yourself coming up with good ideas to pass through whatever process they establish to prioritise the proposals and develop it. Another one over this side.
Hi, Karen Zwee from Sydney Children's Hospitals Network. The focus that you've spoken about largely rests at the end of the clinical care continuum, so people who already have chronic care and require a less complex system to address their healthcare needs. I understand that, but it's similar to the equity question. How far back are you interested in the addressing fragmentation going? In other words, those of us working in child health probably have opportunities to actually prevent, in a primary prevention sense, those adults who will later present with chronic conditions, so disability, injury, asthma, and a range of other things. Can you conceptualise this sort of funding going towards that primary prevention? And if so, the 3-year outcome framework would be very challenging,
Yeah.
but some way of looking at that.
Yeah. Look, it's a challenging question. And certainly while we're not expecting all proposals to be focused on older people with chronic and complex disease, we're completely open to proposals that are dealing with young people. Indeed, one of our demonstrator sites is actively working with young vulnerable people in their community. And we're looking across all clinical conditions, mental, physical conditions, and certainly integration of care for children is equally applicable for processes. This funding, however, I think is not a population health funding pool. So where we are looking to do things like increase vaccination rates, for instance, there are other funding mechanisms to do that. This is very much around improving that interface between primary care and acute care and making sure that those fragmented parts of the system, some innovative approaches to joining those up are there. So, without seeing the specifics of your proposal, I can't rule it in or out, but that's the general sort of take. I don't know if anyone of the others want to add anything to that. Okay. One here and one here.
David Sinclair from Paraquat, New South Wales.
Sorry.
That's okay. Just in finding and getting linkages with other like-minded people in this whole program. We're an NGO, and obviously we do have a lot of links with various other organisations, but it's also getting some other linkages that could actually help get our concept up. Where would we go to get those sort of linkages?
Yeah, so I'm hoping that one of the reasons for bringing you all here today is that you'll have conversations with each other, and there will be partnerships formed partly as a result of the people in this room saying, well, actually, I can see that there's an opportunity to partner with those people. So we haven't facilitated a process of dating, and we would encourage you, if you have specific ideas, to take them to the relevant local health district that you want to work with. And I think it'll be incumbent on the local health districts to act to ensure that the right partnerships are formed for their local context. So in the first instance, if you don't have clear ideas, by all means, put your hand up and see if anyone does want a date, but go to the local health district. So we had another one over here.
Yes, Louise Dever, Southern New South Wales Local Health District. I'm sitting here next to my partner from Medicare Local, and just wondering how the Medicare Locals are going to fit within the scheme of I'm sure there's a number of bids when we don't know what they're going to be looking like in their primary health network entity.
Yep. Yeah, so it is somewhat challenging in the current timing of the transition to primary health networks to clearly articulate that. I think whatever primary health networks become and whatever role Medicare Locals have in those bodies, it's going to be critically important that local health districts have partners in primary care. And I think there are sufficient signals in the statements that have been made by the Commonwealth about what the primary health networks are going to contain and their roles to perhaps guide some of your thinking about how you can best engage to ensure that there is a continuity of partnership with primary care, because it is crucial. What we don't want is a change from Medicare Locals to PHNs to derail all the very good cooperation that New South Wales Medicare Locals and LHDs have generated over the last couple of years. And we're continuing to try to emphasise to the Commonwealth that we need 15 primary health networks in New South Wales. So all of you who know the federal members, write to them, 15 primary health networks for New South Wales. Betty.
Thanks. Look, I'd like to begin by, my name is Betty Johnson and I'm the Chair of New South Wales Health Consumers. I'd like to begin by thanking Rowan. I don't think I've ever been to a meeting, and I've been to many, where I've heard somebody speak about the people who use the system as Rowan has. He not only talked about us, but he focused on us, which I think was very good, and I thank you. And I'd also like to thank Catherine too, because it was about 12 months ago now that I first heard Catherine talk about integrated care, and I've talked to her a few times since then, and what I've learned, I've talked to a lot of consumers about it, all ages, and they are waiting for this to happen. They want it, they like it, and I think that's the important thing to know. But the question is, so how are we going to implement it without imposing it on consumers? Consumers have got to be involved and they've got to be listened to. And remember from the Mid-Staffordshire stuff, the problems you have when you don't listen to consumers.
Yeah.
So I really do think that I'd like to hear from you what we're going to do to work together on this, so we just don't leave it to each of the LHDs to do it their way, because in some cases it won't happen.
Yeah, yeah. So I think one of the challenges is to all those people applying to remember that at the focus of all of this is definitely an expectation that the proposals are dealing with this issue of the system being designed around the needs of the patient. So it's a crucial part of how we're going to evaluate your proposals, and you need to be mindful of that. Betty's challenge to all of us is to make sure that we're working in partnership with the community to ensure that what we're designing in this process actually meets their needs, and that's an ongoing piece of work. This innovation fund needs to ensure that that happens at a local level, and of course at a whole of state level. That's an ongoing piece of work, and that engagement with the community in designing the best models of care is crucial. Yeah. Any last questions? I'm mindful that we are at time. There's one at the back, one down here. I'm happy to go over answering questions, but I'm also mindful some of you may want to talk amongst yourselves. So down the back.
Yes, thank you, Rowan. Steve Frosty, Advantage Systems. It's just a clarification question. In the document it mentions information technology and communications around the funding. Is video conferencing within the LHDs, or is it a statewide initiative?
So video conferencing, so the state has a telehealth investment strategy, and that's, largely bought a whole lot of hardware, and I think it's now at a stage where the maturation of use of that video conferencing process needs to be built into local health district processes. So there's nothing that would exclude proposals that focused on that within an LHD or between several LHDs. Yep.
Vicky Rose from Northern LHD. Following on from that man's question was about not funding infrastructure, but my question related to that IT and being a rural area, always a bit behind. So would that prohibit those, the use of tablets, the purchasing, the investment in that area?
So we do have a separate bucket of funding for the statewide enablers, which are those large whole of system IT things, but also potentially some of the smaller capital, because largely our IT, when we expend IT costs at a government level, it's built into our capital program rather than our recurrent program. We would certainly consider proposals and work out whether they were applicable for this funding stream or whether there were alternative approaches within the bucket of money for the program generally. Yes.
Hi Rowan, Angus Ritchie from Sydney Local Health District, and I'm a clinician, but I work within the Health Pathways program, and at every single meeting the GPs ask us about secure messaging or various flavours around that and how we share information. I'm looking for some clarification around whether secure messaging is a statewide enabler. It almost seems like a federal enabler, but if we're going to make investments around secure messaging, it would be silly to do it if it's being dealt with at another level.
Yeah. So part of the rollout of HealthyNet enables us potentially to exchange information in a secure environment with the primary sector. And that is a significant investment at the state. New South Wales will be the first state in the country to have a fully joined up health identifier for the 7 million people in this state. We'll have that by the end of this financial year is the target date on HealthyNet rollout. And that will then, over time, and I have to say not immediately, allow linkage with primary care most of the rate limiting part of that linkage with primary care is the fact that a relatively small number of people are currently enrolled through the personally controlled electronic health record. If we can get all 7 million New South Wales residents linked up to that, we then have a vehicle that we can join up in an electronic health record transmission secure linkage system through HealthyNet. So I'd encourage you not specifically to develop within your LHD a new secure messaging system with your primary care partners, because that's underway through the eHealth strategy. If there's some specific innovative approach to transmission of information that can be tested, demonstrated, developed and worked up at a local level, with a view to eventually linking into that HealthyNet arrangement, then that's a different thing.
Peter McGeorge from the St Vincent's Inner City Health Program. Given the importance of NGOs in an overall system of integrated care, could you make some comments in terms of whether NGOs will be considered primary health care providers, and will they then be able to be linked into the electronic communication systems?
So certainly NGOs would be considered primary healthcare providers if they provide primary healthcare and would be suitable as one of the partners that LHDs might work with. We are looking to invest in, at a statewide level, an IT solution that will allow sharing of certain parts of information amongst all providers, so that, and I guess this is lessons that's come out of us looking at what's happened with accountable care organisations in the United States, where some of you will be aware that under the Obama reforms, there was incentive funding for hospital systems to partner with NGOs, with community care providers. Some of those programs invested a huge amount of money in designing a fully linked up electronic health record. Largely they haven't worked. They've been very expensive, difficult to manage, suffered all sorts of privacy constraints. Others have developed very simple web-based information exchanges that allow those people who are touching the patient at different points in their healthcare journey to see enough information to keep all their partners in their care informed about that process. And so at a statewide level, we're looking to develop that sort of simple web-based technology that would allow adequate information exchange with appropriate safeguards. Okay.
Vicky Rose again from Northern. Can you just provide some more details about the risk stratification approach that you'll be developing at a statewide level, particularly in relation to how that might be used for any submissions that we're putting forward?
Yeah, so look, frankly, it won't be ready for your submissions. There's a documented literature around risk stratification in different populations in the healthcare system, and I'd encourage you to do a bit of reading around that. Our demonstrator sites are looking specifically at how they can understand the risk stratification of the populations that they are working with. And as I mentioned earlier, the first place I'd go within your own organisations in understanding who are the population groups that are most at risk of fragmentation is look at that activity-based management portal, where your LHDs have all the information about every patient that's treated in your system. You know exactly who are those who are at most risk of readmission. You know those who are the frequent attenders. You know those who are the most expensive in their care needs, and you know those who are falling through the gaps, who aren't getting treatment. So I'd start by looking there to target the particular groups you want to look at. All right, so we may have exhausted things. Nigel, Ken, Catherine, any final comments? Thank you all very much for your attendance. The application is on the eTender website now. If there's further information you require, please get in touch with us, and I would encourage you to see if there are partners you want to deal with in this room and have a chat today. Thanks very much for your time. Cheers.